lymphoma. In non-Hodgkin's lymphoma, B-cell lymphoma is more common than T-cell lymphomas. And DLBCL is the one of the most common lymphomas all across. If you look at all the subtypes, the high-grade B-cell lymphomas, which constitutes DLBCL, high-grade B-cell lymphoma, NOS, and other dominant triplets, all these subtypes are the types which are very common. And coming on to the principles, see, most important thing which people need to understand is if you look at the treatment for DLBCL, the first treatment is always the best treatment. Uh, how much ever you want to treat and cure more and more patients in the first line, that is the best treatment which you can give to the patients. So whatever be the second line, third line, all will reduce the cure chances. The first treatment is always the best treatment, and how quickly you achieve the treatment is also very important. And toxicity, again, very aggressive treatments have more toxicity, and how much less toxic you are going to make the treatment is also going to help the patients. So again, in the first line treatment, about 60 to 65% of the patients get cured with the standard R-CHOP in most of the occasions, except for a few occasions like double-hit lymphomas, breast lymphomas, HIV-associated lymphomas. These are the lymphomas wherein the patients may not achieve clear cure with R-CHOP. But in most other occasions, you would achieve about 60 to 65% cure with the first line treatment. But if the patient has a failure subsequently, we have second line treatments, especially the second line treatments, the cure are not going to be great. If it's going to be a CAR T cell treatment, the cure is about 40 percentage, 35 to 40 percentage in the longer run. And if it's going to be any other standard transplants, it's only going to be 15 percentage. And this is something the reality again, how much ever you want to cure in the first line is the best option to give to your patients. Again, CHOP was the standard of treatment in 1976, and R-CHOP became the standard of care in 2002. After the MINT trial and the other trial, which brought in the approval of R-CHOP. After that, about 2 long decades of time, 2.5 decades, we don't have any much of new treatments available for R-CHOP. People did try again in real BCL in Indian outcomes again. 2 year PFS was 69 percentage, and again 2 year OS was 79 percentage in a group of patients, which is published by the famous HCC data. And again, you need to evaluate the IPA of the patients, the age of the patients, because all patients would tolerate R-CHOP clearly, GCB versus non-GCB, dual expressor, double expressor lymphomas, double hit lymphomas, triple hit lymphomas. All these things that need to take into account when you go when are going to treat the treatment. Okay. So again, over the past 2 decades, people did try to enhance the R-CHOP to various. They try to change the CD20 partner. Like basically, they tried obinutuzumab with CHOP versus CHOP. It did not benefit. Again, addition of additional target therapy like addition of lenalidomide, bortezomib, ibrutinib, and even bevacizumab was tried, which is very wondering that why bevacizumab was really tried. Now, all of them did not have any additional treatment, did not have benefit over R-CHOP. And change of chemotherapy, whether gemcitabine addition or going on to add more intensive regimens like EPOC, RCHOP, intensification of regimen into RCHOP 14. And also did not even the latest trial, which has been missed out here, is venetoclax with RCHOP, did not benefit. And moreover, intensive chemotherapy did reduce the survival in DAR, EPOC, and venetoclax with RCHOP. Like maintenance therapy, Astrazin, everolimus, rituximab maintenance, and a lot of other things did not even make any differences. So all these options failed. After all these failed options, people were very much trying to improve the outcomes of our job, but none of these options have really made a difference. And coming on to this, after about 20 long years, after a struggle of multiple clinical trials, at last patients did have a, real outcome, which is polatuzumab. Again, polatuzumab was approved by the FDA, European Commission, all these things in the past 2 to 3 years. And polatuzumab is basically a antibody drug conjugate. It's basically a targeted toxin delivery system. CD79B is the target, wherein the once the target is bound by the polatuzumab, the vedotin which is the MMAE, which is a potent microtubule inhibitor, monomethyl auristatin E, is linked to the peptide to the protosumab, which is cleaved once it is inside the cell by the cell's own metabolism, and then it is toxin is delivered into the cell, which is having the CD79B. Basically, I call this as a targeted toxin delivery system. And coming on to the Polaris trial, which got in the key trial, which is the got in the approval of polatuzumab vedotin in the first line DLBCL. So basically, they tried Pola RCHP. They cut down the vincristine because cross reactivity. Basically, vincristine also increases the toxicity of the neurological toxicity. Polatuzumab vedotin group causes increased neurological toxicity. They had to skip the vincristine, but the standard R-CHOP. So this is a double-blind randomized trial. Basically, it's a double-blind trial. So they include all newly diagnosed untreated DLBCL 18 to 80 years of age, IPA of 2 to 5, and the ECOGPS of 0 to 2. And the stratification was done by IPA score of 2 versus 3 to 5, and bulky versus non-bulky, and geographical regions of European countries, Western countries versus Asia versus rest of the world. So the randomization was 1:1 versus Pola RCHP versus R-CHOP. And then they also added two more cycles of tuximab only after the treatment for both the arms. The primary endpoint was PFS, which was investigator assessed. The secondary endpoints were EFS, PET-CR rate at the end of treatment, DFS, OS, and safety. So again, if you look at the 5-year follow-up of the study, PFS at 2 years was showing a clear benefit with the use of Polar RCHP. The EFS at 2 years was 76.7% versus 70% with Archer. There was about 6% incremental absolute benefit, and the relative benefit was about 28 percentage relative benefit and a 6% absolute benefit. Even a 2 to 3% benefit is really a great outcome when you look at the DLBCL per se. When you are going to get incremental benefits, we are really happy because you're going to cure more patients. And PFS of 5 years, and again clearly shows that it is 64.9 versus 59.1. The PFS has an incremental again benefit of 5.5 percentage at the end of 5 years, and you have a 23% relative benefit across that 5 years. And patients with fewer subsequent therapies were required with R-Pola CHP. So, like basically, you look at the R-CHOP and again, versus R-Pola CHP. R-CHOP required more subsequent therapies like every other therapy, like CAR-T, stem cell transplant, bispecific, any other salvage treatments. All of them were more with the use of R-CHOP than R-Pola CHP. If you look at the OS, again, OS is not yet really matured, but it's slowly, you can see the curves are different. And slowly the curves are getting, uh, slowly the curves are getting separated. You can see maybe we need some more time for this data to get matured in terms of OS. Sorry. But if you look at the Asian part of this OS, you can clearly see that our polar CHP is clearly separated even before 1 year time point. And you can clearly see that OS is benefited. And you can see the OS 5 OS is 84.6 percentage with a 77 percentage. But still, we need time for data to mature in terms of OS. Because PFS itself is a very good endpoint. EFS is itself a very good endpoint in lymphomas. Most of the occasion, when you fail, you clearly know that you're not going to do well. And if you look at the subgroup analysis, all the subgroups clearly benefited uh, with the use of R-Pola CHP, except for these small subgroups like nanostring GCB subtype, which is sitting in the middle, and the nanostring unknown subtype, which is going towards the other side. So the ABC has a very phenomenal benefit. But one thing we need to clearly see is here what we do in our day-to-day practice is not GCB and ABC by nanostring. We are not doing gene expression profiling. We are just doing IHCs, and we are correlating with Hans algorithm for looking at GCB and non-GCB. but we are not doing nanostring. Again, the correlations is not 100%, it's only 80% correlation between nanostring and the Hans algorithm. So this is again DLBCL is a waste basket diagnosis. I always tell my residents that DLBCL is a waste basket diagnosis. You tend to pick up new subtypes every other 2 to 3 years. You tend to pick up new subtypes of DLBCL and then declare it as a new subtype. And again, this keeps on updating. Initially, we were using IHC. Initially, it was morphologically even mantle cell disease and all was available. It was morphologically picked up. Then it was IHC which picked up. Then slowly, when we come to the molecular profiling, gene expression profiling, we have more and more subtypes coming into the picture. We have the genetic subtypes of like C1, C2, C3, C4, C5, and this at this point of time are mostly prognostic, and we don't predict any treatment based on this. And over time, it may become predictive with various clinical trials coming up. So again, if you look at the cell of origin, again, ABC subtype derived excellent benefit with the use of R-Pola CHP and GCP subtype was basically the subgroup analysis. I would not go much dig into the subgroup analysis here, and it clearly shows that almost R-Pola CHP and the R-CHOP are equivalent here. But when you look at the unclassified subtypes, there's no the numbers are very small to make a comment upon here. Unclassified subtypes do not do much with Polar CHP and ABC as a GCP. This is what clearly, and this is a molecular subgroup to keep in mind. This is not by IHC. This is by a molecular nanostring gene expression profiling, not by our Hans algorithm. And if you look at the subtypes of gene expression like MCD and EZB, these are subtypes which are done very excellently with the use of our Polar CHP. And you can see the subtype C5 and C1 had done excellently with the use of R Polar CHP, and other subtypes did not had a benefit, but did not have a decremental benefit either. But they had equivalently. When you're going to choose R Polar CHP, you can make sure that if it's a patient is GCB, patient is going to do as good as R CHOP. But when you're going to use it for ABC, the patient is going to be very benefit of the use of ABC subtype uh, DLBCL. So again, you don't have gene expression profiling when a patient is really affordable enough. Again, whether it's GCP or ABC subtype, you can't really do the nanostring analysis at this point of time. May not be available at various centers in India. So you can make sure that you can go and do give Polar CHP in a really affordable patient so that your treatment outcomes are excellent, the best outcomes going to give. And dark zone signature. Dark zone signature is something which is going to be changing our treatment, but still these are all experimental, not have come to the clear guidelines. This dark zone signature again, our Polar CHP is going to benefit compared to the R-CHOP. So again, you can see extranodal disease, this DLBCL extranodal disease again had more benefit with the use of R Polar CHP. Again, elderly subgroup have poor tolerance to hard chop, especially in Christian when you give, they are going to the severe constipation and also neuropathy. So the tolerance is very poor to in Christian, whereas in polatuzumab vedotin, the tolerance for elderly people is much better, and hence elderly subgroup had benefited with the use of alcohol CHP clearly. And toxicity wise, you can clearly see that any grade adverse events was equal in the both arms. Grade 3, grade 4 adverse events are also not much different. And serious adverse events slightly higher, but not significantly statistically significant. Dose interruptions were equal. Dose reductions were more with our job. Serious adverse events also in the longer period also was not much different. Again, if you look at the peripheral neuropathy grades, again, peripheral neuropathy grades was equivalent, almost equivalent to our polar CHP with R-CHOP. And again, neutropenia rates was almost equal. Infections were almost equal. Anemia was almost equal. Cardiac arrhythmias was lesser with R-CHOP, our polar CHP. Again, if you look at the thrombocytopenia rates, also almost was equivalent to both the trials. But one thing is, if you look at the solution of neuropathy, the solution of neuropathy, R-Polar CHP tends to resolve the neuropathy sets up most commonly in the highest in the sixth or seventh cycle, and subsequently over the time follow-up, you can clearly see the patients recover this neuropathy. The neuropathic symptoms are getting better over time, clearly. And clearly, the EMA, EHA guidelines has clearly told that stage one and stage two still we consider CHOP as a standard treatment. But when you look at advanced stage and a DLBCL, at stage three or stage four, if you have IPA 0 or 1, then you still go with CHOP. But if you have IPA of 2 or more, then you go for a polar RCHP as a standard treatment. And these are the NCCN guidelines also clearly saying that if you have uh, stage adjusted IPA of more than 1, you can use even stage 1 or 2, you can still use Polar CHP. And in stage 3, stage 4, they clearly give a category 1 guideline outcomes for Polar CHP in the NCCN as well. So to summarize, the Polaris is the first trial after a long series of trials over the past 20 years to give a meaningful improvement in the benefit of our overall CHOP in a clear double-blind randomized control trial. And the follow-up analysis also showed the PFS continues to benefit, and we can have a small OS trend also in the tail, which we can see. And we need to wait for some more time for the OS benefit to happen. And it's very important that our Polar CHP, with our limited access to nanostring and gene expression profiling, we think we need to give the best treatment possible for our Polar CHP is the best treatment as of now possible. And it is category 1 recommendation by both NCCN and also NICE guidelines also recommends this as the UK guidelines. Getting a drug into UK guidelines is always a huge task. And it is recommended by NICE guidelines as well, EHA guidelines as well. So I'll stop with this. I'll be happy to answer any questions. Thank you very much.
Great discussion.
Thank you very much, sir, for that insightful and enriching presentation.
Okay. So may I ask some questions for the discussion sake?
Yes, sir. Please, sir.
Yes, Jayachandran sir. So it's pleasure to listen from you, and it's a uh, it's a you have rightly pointed out that since last probably 20 years we have not done anything in the spectrum of DLBCL, though there are a lot of trial intensification, maintenance, and so forth and so on, but nothing could give a substantial uh, benefit in the terms of what the polar of has given. So to to summarize, who are the patient you would like to go for polar RCHOP, or it's a blanket for the DLBCL, and how you manage
No, I would
usually?
give a clear. It's not a blanket. I would go and see. Still, I know that GCB is in GCB subtype. Polatuzumab RCHP is going to do as equivalent as that of RCHOP. Whereas in ABC subtype, it's a clear winner. So we don't have a clear ABC subtype. Subtyping. We have only a non-GCB versus GCB with using an enhanced algorithm. So when you look at the enhanced algorithm, in non-GCB subtype, I will clearly go for R polar CHP over R's. And in elderly patients, especially over 60, just now I had a patient. Today, just yesterday, I started R polar CHP. He's a double-hit lymphoma patient, basically. It's a GCB subtype. Still, if you look at the data, you can't too much dig into the data, but patient may not really tolerate DA or EPO because he's an elderly 64-year-old with some comorbids and bulky disease. So he may not really tolerate DA or EPO. Giving R-CHOP in a double lymphoma is not going to be of any use.
You are not going to.
Whereas R polar CHP has given some data that it is going to work better than R-CHOP and even R-EPOC. The data are very promising, saying that the data is very promising that R polar CHP is going to work in DLBCL equivalent to the R-EPOC. So such patients in elderly patients wherein the patient may not tolerate R-CHOP, especially double-hit lymphomas, double-expressive lymphomas, I may prefer going for R polar CHP. So elderly patient with irrespective of GCB or non-GCB, I know that R-CHOP is not very good tolerant in this of subtype. So there I would go for R pola CHP, and any ABC or any non-GCB, I will be R pola CHP. This is to nail clearly on that. So young patient with clear GCB subtype, I may prefer to go for R-CHOP for financial reasons, but otherwise R pola CHP is the choice for other group of patients.
So are you using this polatuzumab in the relapse setting too? Have you ever used?
Yeah, I have used in
And
multiple patients
what
for
are
like
the
I have
combinations
used
you
it for
prefer?
with in combination Pola Gemox as a bridging for CAR T and as a substrate treatment. I have even used it for polatuzumab with glofitamab.
Okay.
Okay, most recent patient of mine post CAR T relapse, I used polatuzumab with glofitamab. Still awaiting response. So your the patient not eligible for CAR T, I use polatuzumab with uh, glofitamab. Patient had initial responses and then did not do well. And in UK, I used polatuzumab with BR multiple patients. I
Good.
used even good responses, but I don't prefer to go for bendamustine because of the reasons why the CAR T may not be
Yes.
effective or the bites may not be effective. It is a
True.
very T cell depleting treatment for depleting treatment, so I may not prefer to go for bendamustine. But we have
Lymphodepletion can happen.
Polagemox
So
now
CAR
coming
T
up
cell
very
can
much.
have the negative impact on the CAR T cell therapy. So
Yeah,
that could be one of the potential reasons that what we are not doing with the bendamustine rituximab along with Pola. Okay. So great, sir. Thank you very much for your discussion. Okay.
thank you, sir. Can we go on to
Uh,
next session, sir? Session, please. Can you
yes, sir,
introduce,
yes,
sir?
sir. Sir, Chinmay, sir, increase the laptop volume once, sir, because
Yeah.
you're,
Okay. Let me check with my microphone. So
sir, your voice is perfect. I
am I
think.
audible
Yes,
properly?
yes, yes, sir.
I have put my microphone. Okay.
Okay, sir.
Sure. So let me upload my slide.
Sir, after introduction.
Okay, please. Thank you.
So we will now move to our next session on logistics, lighter and edge, agnostic IO-therapy in CHL by Dr. Chinmay Kumar Pani, Senior Consultant Medical Oncologist, Utkal Hospital, Bhubaneswar. Sir, thank you for being with us today. We look forward to learning for your expertise. Over to you, sir.
Yeah. So thank you, Subhasri, and thanks, Joy Chandran sir. And let me share the presentation. So I think I am audible and my slide is visible.
Yes, sir. Yes, sir.
Yes. So my topic today is age agnostic and logistical and lighter iotherapy in classical Hodgkin's lymphoma. So coming to the Hodgkin's lymphoma in Indian context, if we look into that at any point of time, the hyperprevalence is almost in the range of 28,000 to 30,000. The incidents are in the range of 10,000 and the mortality are in the range of 3,700. We all know that it has a bimodal distribution with the mean is almost 34 to 38 years and almost it has little bit of male predominance. And coming to the first the controversy what we see in daily practice, that in many of the patients we saw that tuberculosis as a
misdiagnosis in the Hodgkin's lymphoma patient that may precede or that may marsequading. So I don't know what the exact line to be used. For instance, publication from PGI Chandigarh, where the 12% patient received empirical ATT before Hodgkin's lymphoma diagnosis. And the common reason was that clinical radiological finding and granulomatous inflammation from the FNA. And the participant who received empirical ATT had a longer duration of symptoms and higher incidence of the advanced disease, but probably a comparable response rate and overall survival that is the stage specific. The other publication from the pediatric subgroup. So this is the multicentric prospective study. 396 patients, 12% children had received ATT prior to the diagnosis of Hodgkin's lymphoma. They have more advanced disease, B symptoms are more, and they mostly taken 6 rather than 4 cycles of chemotherapy. Intradiaphragmatic with stage 3 to involvements are more, and they have a comparable overall survival and also they went to survival. Coming to the consortium data recently published, that the treatment practices and outcome of advanced Hodgkin's lymphoma in India, an analysis from the Hematology Cancer Consortium, and there are 1,500 odd patients, 10 centers in the year of 2020-2023. So advanced cases, stage 3BX to stage 4, diagnosis is almost 57%. Median age is 34 years, stage 4 63%. Two-thirds of the patients have the B symptoms, bulky disease 20%, extranodal almost 44. Most regimen used, the treatment received 81%, ABVD, the most commonly used regimen, almost in 90% cases. Interim response done in 84, 80% WBC PET CT. Overall response CR 82, overall response 91. Two-year EFS is almost in the range of 80%. So interim PET is the strongest rate of the event-free survival, outperforming the traditional prognostic marker like that of the IPS scoring. If we look into the NCCN practice guideline, the interim PET is a pivot decision maker. If we look into the RATHER data, the response adjusted therapy in advanced Hodgkin's lymphoma. So advanced Hodgkin's lymphoma, 82%, though it's not a classical Indian data, but the more or less the 0 to 3, 82%, 18% is IPS 4 to 7. The low risk, they go by the ABVD, and if the PET is negative, which is 85%, they go by the ABVD, where the PFS is 90%. If the post 2 cycles, if the PET is positive, then do biopsy, whatever you do, and go by the skeletal curve where the PFS got almost the level of 66%. If it is diabetes 4 to 7, the escalated BICOV and the brentuximab AVD, and where brentuximab AVD has the PFS in the PET negative, and the PFS was almost 85, and those who are PET positive, it was 57%. Escalated BICOV, those who are PET negative, you will go by the AVD where the PFS 92%, and those who are PET positive, again you go by the dose escalated BICOV for 4 cycles where you got a PFS of almost about to 73%. So in the NCCN 2026, total primary treatment from 18 to 60, more than 60, and it's not the elderly. So in the 18 to 60, the new entrant is the Nivo-AVD as per the data set, and the more than 60 year and candidate for anthracycline. So 1 to 2, the ABVD 2 or 3 cycle followed by the ISRT. So giving 2, give ISRT, 3 plus or minus ISRT for you can eliminate. And the stage 1 to 2 unfavorable disease. So here the new addition was Nivo plus ABD, before the ABVD, ABVD plus ISRT, and rituximab 2 cycles followed by ABDC cycle, and the followed by the rituximab for 2 cycles in PR and CR patient. That could be, and that could be a portion of the data. And stage 3, 4, the Nivo-AVD, which is the most preferred regimen now, or brentuximab 2 cycle followed by the AVD 6 cycle. and followed by the bendosmal 2 cycling patient with CRNPR with no neuropathy that contraindication to the checkpoint inhibitor. Those who are elderly, you can go the Nivo or Pembro plus and minus ISRT, and the brentuximab plus Nivo plus and minus IRT, brentuximab plus DACA version plus and minus ISRT. If you go by the data of Vindastin plus Nivo, there are data on the Vindastin plus Nivo. The bleomycin data in elderly, which is not there. So now we are phasing out from the bleomycin to non-bleomycin regimen. The famous regimen of the Bonadonna, I think, from 1971, which got uh, the comparison with the MOP regimen got into the practice almost in 83, almost the 40 years the Bonadonna regimen ruled, starting from the famous Milan University. And so also the ESMO also more focused, and they put the age bar of 80 years in the advanced disease that you could go by the Nivo everyday, and less than 60 years they go by the Breckard regimen, which is brentuximab plus etoposide along with the DACA with indexing percent cyclophosphamide regimen. And and also if the effect is negative, go by the two cycles of Breckard more, or if dual is four to five, then give four cycles of Breckard and then plus and minus ISRT if it is positive. So the discussion of focus that frontline niveau in the classic lymphoma. So where is the unmet need in the Bentus myopathy? In Bentus myopathy probably has not taken the the pickup and the Nivo EVD data came. So the incorporations of the ADC of CD30 directed antibody drug conjugate is into the treatment, and that leads to improve outcome. And the challenges are it necessitates more growth factor support, more toxic regimen, poorly tolerated in the older people, one-third discontinuity, the treatment early, high mortality, and relapse remains the problematic later on. So if you go to the stroke 18260 data point, 970 odd patient is taken to 12 year, good performance status, newly diagnosed stage 4. The stratification was 12 to 17, 18 to 60, more than 60 age, IPS 0 to 3, 4 to 7. RT intended, end of therapy RT intended, yes or no. Nivo every 6 cycle, and the dose of Nivo is 40. Rituximab every 6 cycle, and almost it is same GSSF is required. And the primary endpoint was previous, and the second endpoint was GFS OS, end of therapy CMR rate, and this is reported outcome. The 2 year progression-free survival, 83 in the brentuximab AVD, in the Nivo AVD it is 92%. 2 year overall survival not yet settled, 98 and 99. So coming to the subset analysis of the PFS consistent across all subgroups, whether it is age 12 to 17, 18 to 60, more than 60, IPS low versus IPS high, stage 3, stage 4, with or without these symptoms, the benefit of comorbidity compared to brentuximab in adolescent, adult, and which is sustained in the 3 year follow-up also. And the key point is that in the Nivo, they have better progression to survival, fewer side effects, and almost no radiation. 1 to 2% actually got the radiation group in the Nivo AVD group. And it's better in the elderly because ventricular AVD is poorly tolerated, but Nivo AVD outcomes are similar to the younger patient without increasing the morbidity and mortality. The 3 year PFS looking into the Nivo-AVD, it is 91 versus the Nivo-AVD, brentuximab it is almost 82% of the median follow-up 3.5 years. This is how it got the approval in the April 2000. FDA assigned the prescription drug users to act in the PDUFA goal date in April 2026. And in the December 26, the US FDA granted the priority growth supplemental biotech license application for the people those who are more than 12 years of age, the sensitive people of more than 12 years of age. The SWOG subset analysis of more than 60 years of patient, those who are more than 60 years. So Nivo IBD versus brentuximab IBD, the 50 patient in total. Follow-up is 2.1 year, 2 year PFS is 89 versus 64. OS is 96 versus 85, and the p-value is 0.005. Dose reduction in the nivo 31%, discontinuation is 14%, non-less mortality is 6 versus 6 in the bentusmab ABD. So despite more neutropenia through nivo febrile neutropenia, sepsis infections are higher than the bentusmab ABD as well as the peripheral neuropathy. So, and the patient reported outcome of a key adverse event confirmed the improved toxicity profile of the nivo over the bentusmab ABD. So if we look into the data of SD21 phase 3 BCOP versus record, the Echelon ABVD versus Bentuximab ABD and the BV-ABD versus the Nivo ABD. If we analyze almost the inclusion criteria in this group, that the SWOG analysis, SWOG people, they got the patient younger, this is 12 years, plus 0.01. ACL subset is almost in the SWOG trial, it is about 4% and 2% for the BV. Stage 3, stage 4 people, 60% in the Bentuximab versus Nivo is almost 62%. The high risk IPS was 32% to both groups, where the ABVD, the Echelon trial is 25%, 21% for Bracard and Pickup. So interim PET was not been done in the SOAP study where the Echelon and the SG21 they have done the interim PET. Duration 24 week, almost 24 is in the both the trial, except the BICOP and the Bracard, it is almost on 12 to 18 week. The number of visits in the BICOP regimen was more, but the number of visits in the SOAP trial and the Bentusmab AVD is almost normal. The PFS rate, looking at the PFS, I have already told the 2-year PFS, the Bentusmab AVD is 83, 3-year is 82, but the Nivo AVD 2-year is 92, 3-year is 91. And where if you look into the Beccard, the 3-year it is 94 and 5-year it is 93. Beccard is also seems good. And the hazard in the 3-year is 0.63, the 5-year is 0.64, and the Echelon trial it is 0.77 and 7-year is 0.68, and the Riverview versus the Bentusmab will be the trial the 3-year the hazard is 0.48, which is quite significant. OS rate is not mature; they have not the differences are not seen in this work and the Riverview, where the OS rate in the BCOP and the Bricard, this Piper is 98, and in the both side Piper is 98. In the ABVT and the Bentusmab ABVT, the Piper is 89 versus the versus is 94, and to your event-free survival is 81 and 90 in the Bentusmab ABVT versus the ABVT in the slope data point. And also they have what I have told the GCSF use is optional in the SWIFT data point, but the bentusmab point bentusmab 97%, but the Nivo ABD 56%. So this is optional GCSF use. I can say the radiotherapy, the end of radiotherapy utilization was less than 1%, significantly less. If you look into other trials, the it is more the and the rest other part the infective complications was comparatively low in the nivolumab ABD, and the except the thyroid dysfunction, which is a immuno problem, which is more in the nivo ABD than that of the bentusmab. So that part should be very, very clear what I wanted to say. The immune-related adverse event should be discussed with the patient. That is what I want to say. The mitigations of risk associated with doxorubicin exposure, the higher cumulative dose of doxorubicin associated with increased cardiotoxicity in the breast cancer, and the doxorubicin dose with the cis-cyclic vulnerability higher than the comparative pediatric uh, regimen as well as the big cough in the break card. So that's the one fact I like to focus on because of pediatric. And the concomitant, that's the reason, the concomitant use of dexazoxane may be protective of the late onset cardiac disease, especially in the absence of radiotherapy. And the considerable decrease in the radiation is expected to help to mitigate the future breast cancer risk treated with the nivolumab regimen if you go by the pediatric trials where they try to omit that because of the potential malignancy. This is the real world evidence data of the nivolumab from US 20 centers. The efficacy was 85% had an interim PET of the 2 to 4 cycle. The interim overall response 97, the CR 78. End of therapy overall response and the CR is 96 and 90 and median follow-up is 10.2 month and 1 year PFS is almost 93.8 and 1 year OS is 99.1, which is in line to the data set. And coming to the focus point, that immunoadverse event, hypothyroidism 7.9%, hepatotoxicity is 1.6 with grade 3 toxicity 3.3, inflammatory arthritis 3% grade 1 to 2, RAS is 2.6, colitis is 1%. So we all know you're probably more habituated with the use of the nivolumab in various other indications, probably the 16 to 20 indications available with the registered in India. So we need to sensitize ourselves, probably more sensitized because we always try to cure the disease which we are treating. That is the Hodgkin's lymphoma. That's the reason we need to be very focused on the early detections of the toxicity and manage. So the swab data versus the real world, almost I think similar, but we are in habit to do the interim PET where the data in the swab data they have not done the interim PET at cycle 2, post cycle 2, but in the real world evidences and we are probably more habituated or reflexively we're doing it. So that could be the reason. There's other part. I think the 1 year data point is 93.8, the OS is 19.1, and two EFS have not been declared because they have treated only for the 10 months. So rest other part, I'm okay with the outcome. The GCSFU 64% will give the GCSFU neutropenia percentage. Any other things also the thyroid is 10% to 7.9%. So almost it is sync with the the real world evidences. So this is a case given to me and to dissect. It's a 60-year-old female diagnosed case of acute lymphoma stage 3 nodal sclerosis with IPS3, multiple nodal station, suprainfradigmatic, and the baseline PET CT is a hypermetabolic lymphadenopathy in the cervical mediastinal abdominal node, and there is no frank external involvement of the W4 and 5. So basically, the point of concern with good equity person status, hypertension, CKD. But then in this segment, what do we do because the patient is 50, 60 plus years? So basically, we need to do the geriatric assessment, the supportive care and the functional surveillance, if you look into, they have allowed for the prephase therapy of giving steroid. Growth factor support is probably are more keen to prophylaxis and monitor symptoms is mandatory. Organ function surveillance is a part of the therapy protocol. And dose adjustment schedule modifications we have uh, you have doing we're probably more reflexive of doing it even if we even practically we need not do the geriatric comprehensive assessment too. So when the patient is fit, where you feel that it is just a number, you go by the regimen value of the liver ability, where you feel it is unfit, the therapy is fit or fail. So individual treatment based on the functional status and the patient preferences and the best that we may be considered. But if you uh, the patient is frail, then the and where we have we plan to give attenuated anthracycline therapy in treated cases or pitotin plus Nivo or dacarbazine plus QG or the alone can can be chosen. So Nivo AVD is a new standard of simplicity and safety in advanced NHL. Those who are actually fit and the extent of the use from the 12-year to almost in the range of the 80 years, where you have a clinical efficacy in ease of use. It is simplified all-comer administration, no multiple collateral thought of logistics and other point, and superior safety and tolerability and what we saw from the various regimen and the compared to various regimen, even with the Bricard regimen, which is one of the very the SG21 the started regimen. So we've already recorded 6% febrile neutropenia versus 28% the Bricard regimen. Severe infection rate in the neighborhood is 3.7, the record is 19%. And side by side with logistics and comparison, it is, and the adherence also, it is good because 9% only discontinued compared to 22% in the Bendusma continuing regimen. So the point to the focus is that it is efficacious, easy to use, superior tolerability, and higher treatment adherence and low toxicity and probability all come out. So this is how the recovery advantage over the record, which is clinically safer and simpler, less hospital dependency, safer for the older adult, protect the younger patient, and the lower hidden burden like the low, reduced disease use, fewer admission, and lower indirect cost and out of the pocket expenditure. It also it is a predictable schedule, so it is lifestyle friendly. So fewer visit, less disruption. So the new standard of care for the advance of lymphoma. And but the considerations what already we told that as we are giving the first line antiviral therapy, we should be very cautious about the suspected the immunological side effects. So we should be very particular of doing the evaluation before and during and after about the fatal complications of pneumonitis, myocarditis, myositis, encephalitis, colitis. They are rare but potentially fatal. So we should be very much cautious and easy to detect, and we have an SOP in our mind that what we will do later on. So so this is the data set for so the Bricard versus the BICOB. So the 4-year EFS with Bricard was 94, 90 was with BICOB. And the treatment related morbidity was significantly lower in the Bricard, that is and than the BICOB with a relative risk of 0.7. So this is the data set what I compared with the Bricard, the previous data point. This is the Bricard versus the curve. And this is how the Nivo in advanced Parkinson lymphoma, the PFS benefit is sustained through the 3 years. So it resulted in longer PFS than the bentusmab plus LED. Higher grade of adverse event in the bentusmab LED is compared to that Nivo LED. And the neuropathy was very less, but bentusmab LED neuropathy is a concern. So this is the advantage of the pay card, and this is how the frontline GoAVD is clinically safer, logistical lighter, and also the diagnostic. So this is how in many ways it is diagnostic, and how the the, the novel immunotherapy approaches for the treatment not only in the upfront but also in the pre-transplant salvage judgment, how it utilizes the PD-1 inhibitor has a better survival than that of the only chemotherapy plus sebentriximab than this. This is how the data is evolving and how we come into the frontline therapy also. So thank you. And the postnatal and maintenance RT consolidation high risk patient, and now how the data is coming out of the control maintenance also the post transplant Juventus plus Nivo in the high risk architectural trial, and how it has been come out, and how the management of the tract interrelation of kidney lymphoma, how the PD-1 inhibitor plus rituximab can be used, can be sandwiched, can be given in the maintenance therapy also. So this is how they have been placed. And these are the various snapshots of the frontline immunotherapy trial that is ongoing, and that may have the potentially they may change the first line and maybe the second line. And the newer therapy, which is probably the Chinese Indianized versions of the Chinese versions of the Indian marketed therapy, so also eager to disrupt probably the space whatever now looks very simple, it may complicate it henceforth. So I think thank you. Closing my discussion. Any comments from Jayachandran sir? I think there's a
There's a comprehensive and nice presentation. Excellently covered a lot of things about Hodgkin's lymphoma. So I just want basically, what is your which patients would you prefer to go for Nevo EVD which patients would you go for brentuximab ABD, and which patients would you prefer to go for Bricab? So that is something people can know from your experience. Whom
Uh,
would you prefer to go for? Or would you prefer to go for ABVD for some group of patients?
Sir, coming to the topic of the ABVD, I think still the low risk group patients, stage 1 to stage 2, and those who are young and fit without any comorbid in the lung, I still prefer the ABVD can be possible in this regard. So coming to the stage 2 advanced disease, then in the stage 2 advanced disease, there you can go by the Bracard regimen or the escalated BCOP regimen. I think that is okay, and so also the Nivo ABD. Uh, the uh, uh, the brentuximab AVD, I'm just skeptical about the toxicity. I feel that Bracot has a space, escalated BCOP has a space, ABVD has a space, and the new ABD you can use from the stage 2B onwards to stage 3, stage 4. The brentuximab ABD, this should be given where there is a potential that the where the immunotherapy is contraindicated. I'll use in that segment in the advanced disease to use the brentuximab ABD. I think
So in an hypothetical scenario, so you start with Nivo ABD, patient develops immune-related adverse event. Would you switch over to ABVD or would you think about switching over to brentuximab ABD in an elderly patient or a mid-age
I
patient?
say if it is more less than 65, I may try for the brentuximab ABD.
Sure.
If
So,
if
how
it
about
is
your experience in salvage therapies in brentuximab?
sir, practically speaking, very less. 2 to 3 patient I have used as a salvage therapy. Uh, uh, in in form of the multiple relapses using nivolumab and pembrolizumab in Hodgkins. There are a couple of patients, and they are long-term survivor also.
Yeah, I see. I have used a lot of patients for brentuximab ABD. Even
Yes,
though before brentuximab was available, we had a compassionate access program. I have used it in salvage therapies as standard salvage therapies for at least a minimum of like 30, 40 patients. And
they
it
not.
beautifully works. And most of the patients, brentuximab works excellently in salvage therapies. And it is
Correct,
the most common salvage regimen when we use before bridging for transplant salvage therapies. I combine with brentuximab with the ICE or brentuximab with the DAP.
correct,
All these things is wonderfully works. Even previously, when we had patients, we had used brentuximab with bendamustine as well.
correct,
Those are
correct.
days, early days when brentuximab bendamustine was being used. The first few patients we used brentuximab bendamustine to take them for transplant. I used brentuximab bendamustine even before allogenic stem cell transplantation after autologous relapses. So we used a lot of patients. Brentuximab as a salvage therapy still has a very good role,
Very good role.
but as a frontline therapy, somehow it is not picked up because of the toxicities,
Because
especially
of the
when you're
toxicity.
going for 12 doses. See, whatever been the dose, whatever in my experience, those neuropathies tend to become very bad when they start going beyond the 8th or 10th cycle.
Yes, sir.
With
Yes,
an
I
elderly
agree.
patient by 8th cycle, they tend to have neuropathy. With a younger patient by 10th or 11th cycle, they have neuropathy. After that, they won't tolerate it. So here we are going to give 12 doses, even though it is 1.8 mg per kg or here 1.2 mg per kg. But still, when we were using initial days, we were not using 1.8 mg for full patients. We are using only 100 mg flat. So in that 100 mg flat, when we reach the 8th or 10th cycle, we tend to have neuropathies. So same here, again, when you are going to cross that fourth cycle of Rituximab ABD, 8 doses, last 2 doses in elderly patients is not going to be tolerant. So that's the reason why Rituximab ABD has not picked up
So most of
very
the
much
time,
in first line.
yes, sir. So most of the time post 4 cycle, we forced to change it to AVD
Mm,
without giving the brentuximab.
yeah,
So that is how we manipulate and manage the real scenario. But it is tough. It is sometimes it is neuropathy is debilitating.
yeah.
sometimes neuropathy
But when
delay.
you are going with the salvage therapies, when you are going to give only 3 or 4 treatments,
Correct,
it
correct.
induces excellent
It is
responses.
excellent response because the hardly 3 doses you are delivering to the patient.
Yeah.
True, sir. Thank you.
Have you used any immunotherapy brentuximab combination in salvage like
No,
Nivo
not yet.
brentuximab?
Not yet, sir. But
Mm.
off late, I am probably 10, 12 patients have exposure of the Nivo EBD, and so far so good, sir.
Good.
So far so
Nice.
good.
Do you use the generic Nivo or the original Nivo?
So initially we were using original, but the price sensitive market working, and so we are not completely away from the original Nivo, but somehow
How
we
are the
are
responses to Nivo AVD?
so,
Generics?
so till now it is good, though the numbers is 10 to 12. So till now the response is good.
I'm a bit skeptical in using even using nivolumab in a curative setting.
I
Generic, I'm still very much afraid of using
I
it.
agree, boss. I
So I
agree.
have not yet used any patients as of now. And do you use 240 mg flat or do you use 3 mg per kg?
No, it's a 240 flat.
Okay.
Ideally, you can use also 3 mg per kg, but I am using 240 flat because of because sir, if it is less than 140, the dose, they are not giving the PAP program for your
Yeah,
country.
yeah.
So there is a lot
Oh,
of
yeah.
disparity. So that's the reason where we're using.
When we have more people coming with nivolumab, we will have more insights.
True, 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 true. So I
By
think
the end of this month, I think
they
a lot of patients, a lot of people would come up with the nivolumab.
true, true, true. So I think they will
Other
give
than
us the more flexibility to use for
yeah,
our
yeah,
specific
absolutely.
patient. True, sir. Okay.
Any other questions for Dr. Pani? Think anything, sir? There are no other questions. Think can we close the session?
Yes, sir.
Yeah. Can we just go with the vote of thanks?
Yes, sir. Thank you so much, sir, for that in wonderful presentation and valuable clinical insights. As we come to the end of today's section, I would like to sincerely thank our respected faculty members, Dr. P.K. Jayachandran, sir, Dr. Chinmay Kumar Pani, sir, for their excellent presentation and valuable time. Thank you to all the participants for joining and making this session interactive and successful. We hope to see you again in upcoming IIO academic initiatives. Have a wonderful evening ahead. Thank you, everyone.
Thank you.
Thank you.
Good
Thank you,
Thank
night.
sir. Thank you to you all. Thank you very much.
Good night.